A while back, I put out a short video called GLP-1s for Life. It got a lot of views and a lot of comments because the question makes people uncomfortable. Here's the question again. If we agree that obesity is a disease, why do we talk about the medications that treat it like they're supposed to be temporary? We don't do that with any other chronic disease. So today I want to actually walk through why and what we do differently in my practice because of it. Obesity is classified as a chronic disease by every major medical body, the AMA, the World Health Organization, the American Association of Clinical Endocrinologists. That is not a technicality. It means the same rules that apply to every other chronic disease should apply here too. It has a biological driver, it responds to treatment, and if treatment stops, the underlying disease process is still there. So let's hold that idea next to how we actually treat other chronic diseases in this country. Let's take high blood pressure. We don't cure it, we control it. You take a medication, your numbers come down, and if you stop taking that medication, your blood pressure goes back up because the disease didn't go away. The treatment did. High cholesterol works the same way. Statins don't erase the underlying genetics or the metabolic tendency. They manage it for as long as you're taking them. And with type 2 diabetes, even when we say someone is in remission, that's not the same as cured. Remission means that their numbers are controlled well enough, off the medication or with less of it, that it's no longer causing harm to their body. It still has to be watched and monitored, and for a lot of people, it comes back if the underlying habits or the weight drifts again. Nobody's offended when the cardiologist says, you'll likely be on this blood pressure medicine long term, because we accept that as normal, responsible medicine. So why is it different when it comes to the disease of obesity? I want to be really clear about something before I go further. Nutrition, movement, and behavior change are not optional. They're factors 1, 2, and 5 of my approach, and they're the foundation of everything else. No medication will ever replace them. But here's the honest general picture from decades of weight loss research. For most people who lose a significant amount of weight, and we're talking 30, 40, even 50 pounds or more, through lifestyle changes alone, keeping that weight off for years without any other support is the exception, not the rule. The people who do keep it off long term tend to have one thing in common. They never actually stop treating it. They keep weighing in. They keep tracking. They keep exercising deliberately, indefinitely. In other words, even the lifestyle-only success stories are practicing lifetime maintenance. They just don't call it treatment. So the real question isn't medication versus lifestyle forever. It's what does a realistic, sustainable maintenance plan look like? And does it ever include medication as one of the tools? Now, flip it around and look at the medication side. In the clinical trials of semaglutide, the GLP-1, when people reach their goal and then stop the medication completely, no dose, no taper, the weight did not stay off. Within about a year off of the medication, most of that weight loss came back, along with the blood pressure, the blood sugar improvements that had come with it. That's not a failure of the drug. That's exactly what we'd expect from a chronic disease treatment. It's the same pattern as stopping a blood pressure medication and watching the numbers climb back to where they started at the beginning. This is the piece that gets left out of a lot of the online conversations about these medications. Stopping isn't graduating, it's discontinuing treatment for a condition that's still there. So here's the shift that I want you to make. Stop thinking of semaglutide or tirzepatide as just a weight loss drug with a start and an end date. Think of it as one tool for long-term metabolic control. A tool you might use, step away from, pick back up later, based on what your body needs over time. This is exactly how we use Factor 3, metabolic enhancement, inside our 5-factor approach. And it's different from a lot of the prescription-only telehealth models that you're seeing advertised day in and day out. We treat with a GLP-1 or dual agonist like tirzepatide to get a patient to their goal. Once they're there, we don't just leave them on the medication indefinitely by default. We start weaning them off while doubling down on the other 4 factors of weight loss: nutrition, exercise, hormone optimization, and when it's needed, the psychological tactics that help someone actually sustain new habits. For a lot of our patients, that combination holds the weight steady for months, sometimes even years, without any medication on board at all. Here's the part that makes this real medical maintenance plan instead of guesswork. Before we ever wean someone off, we set a specific weight limit number together, a weight or a range that acts as a trigger point. If you reach that, we're going to go back on treatment. If the scale climbs back up to that line, we don't wait for it to become a full relapse. We restart the medication. We get things back under control and get back to that goal weight. That's disease management. It's the same logic as a cardiologist telling your patient, if your home blood pressure readings go back above this number, call us and we'll restart your blood pressure medication. Nobody considers that an admission of failure. It's just how you manage a chronic condition responsibly. So back to the question I original post. GLP-1s for life? For some patients, sustained low-dose therapy really is the right long-term answer. The same way some patients are simply going to be on a blood pressure medication indefinitely. For a lot of our patients, it's not forever. It's as needed, monitored, and ready to restart if the numbers say so. Either way, the goal isn't just a number on the scale in month 1, it's staying in control of this disease for the rest of your life. The same standard we would hold for any other chronic condition. If you want a plan that actually accounts for what happens after you just reach your goal, you have to have a plan that incorporates all of the 5 factors of the medical treatment of obesity and overweight for the rest of your life. You've got to have nutritional change permanently, exercise consistently for life, metabolic enhancement with medication off and on possibly, hormone optimization if you need it, and that psychological strengthening requires ongoing care. No more diets themselves, no more gym and workouts only, no more I just need a pill or a shot, no more hormone-only therapy, and no more counseling or behavioral therapy as a standalone treatment for your weight. The answer to a healthier, thinner, leaner, and fit life is in addressing and acting on all 5 factors together for the rest of your life. Simple, maybe, but not easy, but doable. This is Dr. Greg Oliver, and I'll see you in my next video, which is also going to be another metabolic enhancement, but timely and concerns microdosing of GLP-1s and dual agonist agents. So long for now.